And with that one, with the patients, pretty much with their leg extended, you're going to, forcibly or passively dorsiflex the foot, and you're looking to see if they have pain or cramping in that calf. You can also go in there and palpate while you do that. Remember we talked about if you're observing their calf and they have any redness, that distinct redness, they have a lot of heat coming off of that calf, it's most likely a blood clot or a thrombitis, and that's something that if you notice a lot of redness, you notice it almost about the size of like a $50 or a quarter in circumference, I wouldn't even do that test. I would just send them out to either an emergency room or their primary doc to just evaluate that a little bit further to see if there is a blood clot there. Because if there is a blood clot and you go and you start messing around and palpating in there and passively dorsiflexing the foot, with some of the complications that can happen. You can move that clot. And usually if it's that distinctive, that inflamed, it could be unstable. So you're better off sending them to like an emergency room, urgent care. They can do an ultrasound and even get the patient on blood thinners just in case that clot does throw. Any questions on that one? I mean, if you want, we could do that one, that's just a good one to know, especially if somebody comes in and they have any sort of lower leg pain or cramping, and, when you start doing some of the tests for, either the knee or the ankle or even low back, like a sciatica type of a patient, if somebody complains of pain in the calf, sometimes you might think, well, it could be a sciatic symptom. Remember we talked about referred pain doesn't necessarily have to go down that whole referral pattern. So this is just a good test to use, especially in your older patients or patients that have any sort of vascular troubles, to just rule that out. So next on the list, Thompson's test. Who remembers what Thompson's test is? What are we evaluating? What structure are we evaluating there? Don't all jump at it. Remember, this is to check the integrity of the Achilles tendon. Remember we talked about in an avulsion or rupture of the Achilles, patient's not going to be able to go up on their toes. They're not going to be able to put full weight on that affected side. But there can also be a rupture of that Achilles tendon. This test is designed to rule that in or rule that out. And basically what you're going to do is, patient either lying supine like this or seated, you're going to take over the action of the gastrocnemius soleus. And you're going to squeeze the belly of that muscle, and you should see, not going to work, but you should see the foot move. And usually that's a sign that the integrity of that tendon is not interrupted. There's no rupture, there's no avulsion there. See that? See how her foot kind of goes down?
It's really tender.
Is it tender? I might be just squeezing too hard. But you're going to go about mid-calf or mid-belly of that gastroc and just pinch down on it. And like I said, there should be, movement of that foot. If there's not, that's an indication that there is a rupture of that tendon or avulsion of that tendon. You might then follow up with, palpation of the insertion point of that tendon on the calcaneus. That's where even, actively and passively, or just passively, dorsiflexion and plantar flexion of that foot's going to help too, and just see if there's any pain or tenderness with that. If you do suspect a complete rupture or even an incomplete rupture, that's something I would send out to an orthopedist. Let them order an MRI. An MRI is going to show definitively, if there's an avulsion or a rupture of that tendon. And, usually at that point, that's where they're going to have to reattach that tendon. You're going to find this in patients, Achilles ruptures, remember, patients that like volleyball players or anybody that comes up and then down on that foot, and there's a forcible, movement of that tendon. Usually, it's been getting weak all along. These are the patients that probably had Achilles pain. Sometimes your runners, they've been straining that Achilles tendon, and it just finally just takes one action like that, and it just pops, it just pulls. Usually, they're going to describe it as, feels like somebody hit them in the back of the foot, or they heard a big pop or a click in that area. But again, that would go along. And then sometimes you can catch it early enough, and that's where the Achilles pinch. Remember we talked about like a tendonitis type of a thing? If you pinch that Achilles tendon, if there's going to be, sorry, I don't mean to like flip you over there, but usually if there's been overuse of the Achilles or like a repetitive strain of Achilles, there's going to be a palpable bump in there. It's going to be a little thicker than the other side. And if you go in there and you just pinch the Achilles, normally, within reason, I mean, you don't want to do the spot grip on it, but within reason, you should be able to go in there and pinch and move it around. It shouldn't be that tender to the patient. If you start doing that, and it is pretty tender to the patient, you notice some redness, you notice that bump, that's a sign of, a tendonitis type of issue, an Achilles tendonitis issue. If you can nip it in the bud, if you can diagnose the treat early, start having them stretch their calf muscles, strengthening, tibialis anterior, those type of muscles, you can prevent a possible, future Achilles rupture. Any questions on that?
Even with the exercises to strengthen the anterior tib, is that risk always going to be there for that patient if they've injured it?
It depends on the significance